Assalamu alaikum. Welcome to another series of webinars by Pakistan Society of Liver Cancer. I want to share an important landmark of PSLC, that it is a registered society with more than 250 gastroenterologists, FCPS gastroenterologists being with us, enrolled in our society. And this era is increasing day by day. And overall, our registration of FCPS and MD fellows, postgraduates and consultants is crossing more than 800. So we have huge participation of young people from GI, radiology, oncology, and liver transplant surgery. Today, we are honored that our chairs include a well-renowned liver transplant surgeon of the country, Dr. Sikandar Aziz Afridi Saab. He is head of liver transplant surgery at Quaid-e-Azam International Hospital, Islamabad. And I am pleased that he remained my teacher here at Gambut Liver Transplant Program. Then I would welcome Professor Sharbat Khan Saab, a well-renowned name in the field of gastroenterology in this country. He is head of Department of Gastroenterology, Bolan Medical Hospital, Quetta. Welcome, Dr. Sharbat Khan Saab.
Thank you. Thank you.
Our panelists include also the renowned names of this country, Dr. Hasnain Baloch. He is assistant professor at Sheikh Zayed Hospital, Quetta, in gastroenterology. Dr. Daud Gilzai, he is also assistant professor at BM Hospital, Bolan Medical Hospital, Quetta. Then we have a well-renowned name of PSLC, Dr. Shahzad Amir. He's consultant gastroenterologist at Maroof and Heart International Hospital. And we have the president of PSLC, Dr. Mohammad Irfan Rashid, as our panelist. He is consultant gastroenterologist and hepatologist and focal person of Punjab Hepatitis Control Program. Today we have two talks on two very important topics. One with two renowned names of this country. One is by a consultant medical oncologist, and one is by a gastroenterologist. First, I would like to invite Dr. Reena Kumari. She's consultant medical oncologist at Dr. Ziauddin Hospital, Karachi, and her topic is very important. It is management of advanced HCC and the upcoming therapies. So on PSLC platform, such a remarkable topic by an oncologist is a luxury to listen. Over to Dr. Reena Kumari.
Thank you so much, Dr. Afan. So should I share my screen?
Ji, bilkul. Yes.
So everyone can see my screen?
Yes.
So, hello, my name is Dr. Reena Kumari. As Dr. Afan has already introduced me, I work as a consultant medical oncologist in Dr. Ziauddin Hospital. So today I will be talking on management of advanced hepatocellular carcinoma and what are the upcoming therapies. So starting with the brief introduction. As hepatocellular carcinoma, it is the fourth leading cause of the cancer-related death worldwide. And its incidence is on rise in Pakistan, and it might represent the most common cancer in adult males, and it may represent 10.7% of all the cancer. And in Pakistan, most of the hepatocellular carcinoma, it mostly occur in the setting of the cirrhosis. And if we talk about the etiology, the most common etiology for the cirrhosis is the hepatitis C virus, followed by the hepatitis B. Then non-alcoholic steatohepatitis, alcoholic liver diseases, aflatoxin, and the obesity and diabetes is also the risk with the obesity and diabetes cirrhosis is also rising in Pakistan. So the survival and the prognosis of the hepatocellular carcinoma, unfortunately, is very poor even in the developed countries. 5-year survival is roughly 10%, and its survival is even worse in the developing countries, and its mortality is roughly equivalent to the incidence rate. So when we talk about the survival, on three things, survival of the hepatocellular carcinoma depends. Number one is the tumor characteristic, which include what is the size of the tumor, multinodularity, and third is the vascular invasion. And second thing is the what are the underlying liver function, which are calculated by the Child-Pugh score. And third is the performance status, which we usually calculated by the ECOG performance status. So on these things, the survival of the hepatocellular carcinoma depends. So they are very important for the survival as well as the treatment. This is the BCLC staging and the treatment strategy. It is this chart is showing the early 2017 treatment, in which in the advanced hepatocellular carcinoma until 2017 only approved therapy was the sorafenib, which is a multi-kinase TKI. And this algorithm you will see that the for a decade only approved therapy for the advanced hepatocellular carcinoma was only sorafenib. But since 2017, a lot of the different therapies has been approved in the second line as well as in the first line second. In the second line, approved therapies are the regorafenib, cabozantinib, ramucirumab, nivolumab, pembrolizumab, or the combination of the nivolumab and the ipilimumab. And in the first line setting, lenvatinib, which was approved in the 2018, and new therapy atezolizumab plus bevacizumab, which was approved last year in May 2020, and it is shown that it is the most superior in terms of the overall survival and different other things. So I will be talking about the SHARP trial as the sorafenib. It was approved on the basis of the SHARP trial in which it was compared with the placebo in frontline setting. But absolute benefit with the sorafenib was only 3 months, and it has also shown to improve the time to radiological progression. Then the second drug, which is the lenvatinib, which is another TKI, it was approved in 2018, and it was compared in the REFLECT trial, which is a non-inferiority trial, in which it was compared head-to-head with the sorafenib, and it was shown to be non-inferior in terms of the overall survival, between the two drugs, but the median progression-free survival was more with the lenvatinib, which was around 7.4 months as compared to 3.7 months with the sorafenib. And the time to treatment progression was also improved with the lenvatinib, which is 8.9 months as compared to 3.7 months with the sorafenib. And third, the overall response rate, which was also much improved with the lenvatinib as compared to the sorafenib. And number four, the tolerability profile of the lenvatinib was more good as compared to the sorafenib. So this in this chart you can see that the treatment emergent adverse effect, hand-foot skin reactions, and the decrease hand-foot skin reactions, and the alopecia was less with the lenvatinib as compared to the sorafenib, but for the hypertension was more with the lenvatinib. So now the immunotherapy has been approved for the hepatocellular carcinoma. So I will be talking about the immunogenic potential of the liver. The liver is an immunogenic organ. 80 to 90% of the circulating immune protein are usually synthesized in the liver. And by its size, it had to be tolerant as it is exposed to all the antigenic food which we eat and the gut microbe. And it has large number of the resident immune cell, a few of which are the Kupffer cell, natural killer cell, invariant natural killer cell, further Treac, T4, T8, MAC1, ICAM1, and sinusoidal endothelial cells, and the many more. And the slow flow, this allow the interaction between the Kupffer cell and the sinusoidal cells. And what is the rationale of giving immunotherapy in hepatocellular carcinoma? And as the liver cancer, which is hepatocellular carcinoma, it has the high rate of the mutation. And we know that the cancers or tumor which has the high mutation rate, it has been observed that it generates the neoantigen. And these neoantigens that initiate the cancer immunity. So initially, immunotherapy was tested as a monotherapy in the second line and then in the first line. And the second line, pembrolizumab, which is a PD-1 inhibitor, it was tested in the Keynote 240 trial, and in the nivolumab, which is another immunotherapy, it was tested in the Checkmate 459. In this trial, it has shown that the overall survival with the immunotherapy monotherapy has not been improved, but the overall response rate with these immunotherapy was more prolonged. Overall response rate was more good as compared to the other TKI. And second is the more many of the responses was the complete response. So idea was that how to improve the cancer immunotherapy to maximize benefit in hepatocellular carcinoma. So let's take the help of basic biology. As we know that hepatocellular carcinoma is an extensive hypervascular tumor, and its hypervascularity, it is driven by the angiogenesis regulator, which is VEGF-A, and its gene amplification, which is more than 4 copies, are found in 4 to 8% of the hepatocellular carcinoma. This VEGF-A, this causes the neoantigen and angiogenesis and tumor proliferation in HCC by inducing the macrophage-mediated hepatic growth factor secretions. And its overexpression is also associated with the poor overall survival and disease-free survival in HCC. So whenever there are high level of the VEGF, it causes it induces the mechanism of immune tolerance. So whenever there is increased VEGF, there will be increased immune suppression by increasing the Treg cells, regulatory T cells, and the myeloid-derived suppressor cells. And then it will decrease the immune cell infiltration into the tumor. And third, it will decrease the immune activation and dendritic cell maturation. So how we can activate the T cells? It is by giving the atezolizumab, which is a PD-L1 inhibitor. It promotes the T cell activation. So whenever there will be activated T cell, when we combine it with the bevacizumab, which is an anti-vascular endothelial growth factor in antibody, or we can say it is anti-angiogenic agent. So when we combine bevacizumab, then it will normalize the tumor vasculature. So there will be increased T cell infiltration into the tumor. And further, this bevacizumab, it also decreases the activity of the immunosuppressor cells, which are the myeloid-derived suppressor cells and the Treg cells. And third is the bevacizumab. It also has the immunomodulatory effect. So it will modulate the effect of atezolizumab. And fourth is the bevacizumab. It promotes the dendritic cell maturation. So whenever bevacizumab is combined with atezolizumab, it increases the efficacy of the atezolizumab by reversing the VEGF-mediated immune suppression to promote T cell infiltration into the tumor. So this was the idea of the IM-Brave 150 trial, in which atezolizumab plus bevacizumab was tested against the sorafenib. It was a multi-centric randomized open label phase 3 trial. It was tested in the patient with locally advanced or metastatic or unresectable hepatocellular carcinoma who has not taken any previous systemic therapy, and the patient should be in child class A and who has the performance status of 1 or less than 1. Total number of patients was 501, and atezolizumab dose was given was the 1200 mg every 3 weekly, and bevacizumab dose they have taken is the 15 mg per kg, which was given also every 3 weekly after giving atezolizumab, and it was tested against the sorafenib standard dose 400 mg BD. Treatment is usually given until progressive disease or intolerable toxicity. The primary endpoint of this trial was the overall survival and the progression-free survival. This chart is showing the baseline characteristic of IM-Brave 150, in which you can see that the more of the age of the patient was mostly in the 60s, and there were male patient were more, and they have included Asian as well as the rest of the world population, and they have excluded Japan from the Asia, and they have included Japan in the rest of the world. So 40% of the patient was from the Asia, and 60% was from mostly 60s, around 1% from the rest of the world. And they have taken the patient with alpha fetoprotein more than or less than the for 400. In this trial, they have taken the patient with a macrovascular invasion and the extrahepatic spread, and they have also taken the patient who have both macrovascular invasion as well as extrahepatic spread. Varices at the baseline, were the patient who has the varices at baseline was 26, and who have the varices treated was the 11 or 14%. And they have taken the HCC etiology, hepatitis C, hepatitis B, C, and the non-viral hepatitis, and they have included in this trial. This is the updated overall survival and the progression-free survival results of the IMbrave 150, in which you can see that the median follow-up 15.6 months, the overall survival with the atezolizumab plus bevacizumab was 19.2 months, as compared to 13.4 months with the sorafenib, with a hazard ratio of 0.66%. While the progression-free survival was also improved with this combination, and the median progression-free survival was 6.9 months with the atezolizumab, and it was 4.3 months with the sorafenib, with a hazard ratio of 0.65%. This is the overall survival subgroup, and in this group you can see that the patient Asian patient has more benefit from this combination of the atezolizumab bevacizumab as compared to the rest of the world. And in the etiology group, you can see that the patient who has the hepatitis C virus hepatocellular carcinoma, they have taken more benefit from this combination as compared to the non-viral hepatocellular carcinoma. And in the patient who has the alpha fetoprotein less than 400, in those patients you can see hazard ratio is less as compared to the patient who has the alpha fetoprotein more than 400. And in the patient who has the extrahepatic spread and or macrovascular invasion, they also has taken benefit from the atezolizumab and the bevacizumab. So this is also same for the progression-free survival subgroup, for the Asian as well as the hepatitis C and the B virus. So the patient who has the etiology of hepatocellular carcinoma with viral etiology, they have more benefit from the atezolizumab plus bevacizumab as compared to the non-viral hepatocellular carcinoma. These are the secondary endpoint of the IMbrave 150. These are the updated responses. So you can see in this trial with the RECIST criteria that confirmed overall survival with the bevacizumab was 3 times higher with the atezolizumab plus bevacizumab as compared to sorafenib. It was 30% with this combination as compared to the 11% with the sorafenib. And some of the responses were complete, 8% with the atezolizumab as compared to less than 1% with the sorafenib, and many have the partial response. Many 44% has the stable disease as compared to 43 with the sorafenib, and some of the patient has still ongoing response, which is 56% as compared to the 28% with the sorafenib. So median DOR is around 18.1 month in the atezolizumab plus bevacizumab as compared to the sorafenib, which is around 14.9 months. And let's talk about the safety of this combination. Patient reported quality of life. It was also much improved with the atezolizumab plus bevacizumab as compared to the sorafenib. So median time to treatment deterioration was the 11.2 months with the combination of atezolizumab plus bev as compared to the 3.6 months with the sorafenib. And in the side effect profile, hypertension and the pyrexia and proteinuria, and of course infusion related reaction was more with the atezolizumab as compared to the sorafenib. We should know that the endoscopy within 6 months of initiated treatment is very much important, and it should be evaluated before starting this combination of the drug, as the risk of the upper GI bleeding is more with the combination of atezolizumab because of the bevacizumab. It was 7% with the atezolizumab as compared to 4.45% with the sorafenib. So any varices should be treated according to the local standard of care before starting the combination of atezo-bev. And I want to add more thing, that the patient who has the prior transplant, they are excluded from the combination of atezolizumab, and they are not, they should not take this combination of the atezolizumab and bevacizumab. And the patient who are are on the anticoagulant for any reason, they also cannot take this combination. So, so the patient has the benefit in overall survival. They have the benefit in the progression-free survival. Quality of life of the patient is improved. Overall response rate of the patient are of this combination of drug is very better. But the only problem with this combination is the cost of the therapy. This is the rough cost estimate. As you can see that the Avastin, one vial of the Avastin contains 400 mg, and the median, if we take the median weight of the patient around 60 kg, so it may take 2 or 3 vials. So the price of the one vial is 114,500, and the with the Tecentriq, which is the atezolizumab, its one vial contains 1200 mg, which is the standard dose, and its cost is 3,55,000. So with a rough estimate, per month cost of the therapy will be around 7 to 9 lakhs. So it is way too much expensive therapy. So for the first time, we have regime that gives superior survival in the frontline settings, and it is supported by the improvement in PFS, overall response rate, and quality of life, and it has the favorable tolerability profile. It sets the benchmark for the median OS in the frontline settings, which is 19.2 months in intention to treat population, and in China cohort and survival was around 24 months. So this was all about the IMbrave 150 trial, which is the approved therapy. And now I am talking about the key ongoing trial for the first-line treatment for advanced hepatocellular carcinoma. In all of these trials, they have combined immunotherapy along with another immunotherapy or immunotherapy with the tyrosine kinase inhibitor. So in the LEAP-002, they have combined lenvatinib with the pembrolizumab, and its supporting data was from the phase 1 study, in which this combination has shown the overall response rate was 36, and median OS was in that phase 1B study was 22 months. So it is not yet approved, but the results, the studies show that it will be approved in the coming years. In the Himalaya trial, durvalumab is combined with the tremelimumab. In Cosmic 312, they have combined the cabozantinib with the atezolizumab, and the Checkmate 9DW, there is combination of the immunotherapy nivolumab with the CTLA-4 inhibitor, that is the ipilimumab. So these are the upcoming therapies for the advanced hepatocellular carcinoma. Trials are ongoing. So let's talk about the second line therapies. Very less number of the patient will reach to the second line therapy if their performance status and if their child class allow, then they can receive the second line therapies. So the trials which have done for the second line therapy in hepatocellular carcinoma, they are just FDA approved for the patient who has previously taken the sorafenib. None of the trial has been taken in the patient who have previously taken lenvatinib or the atezolizumab plus bevacizumab. So the approved therapy is only for the patient who has the child class A. And overall survival was taken in the was seen in the Callisto trial, in which the agent was given was the cabozantinib, and in the regorafenib was seen in the trial was the resource trial, which is given in the patient who has a child class A and who has previously taken the sorafenib. And a few number of the patient whose alpha fetoprotein is more than 400 nanogram per ml, in which they, in those patients ramucirumab can be given according to the REACH-2 study. And now the nivolumab and the pembrolizumab, which are the PD-L1 inhibitor, and these are also recommended for the patient who has child class A, and it was tested in the Checkmate 040 and the Keynote 240 and 224 respectively. And when patient has already taken sorafenib, and if they can take the second line therapy, I would say the preferred choice should be immunotherapy, nivolumab or either pembrolizumab, because the overall response rate was more with this immunotherapy as compared to the other TKI, and some of the responses are also complete responses. So in the last, I would talk about, I put in the few slides about the side effect of the immunotherapy. The side effect of the immunotherapy are totally different from the chemotherapy and other TKI. These side effects are mostly endocrine related, endocrine abnormalities such as the hypo or the transient hypothyroidism, adrenal insufficiencies, hypophysitis, and the other endocrine abnormalities. They could be permanent, and the patient can present to us with the skin lesion from the pruritus to the lichens or other very severe like the Stevens-Johnson syndrome. Patient can have the symptoms of the interstitial pneumonitis. Patient can have the side effect of the colitis, hepatitis, immune-related arthritis, or the myositis, and then patient can have the renal toxicities. So I have shared the few pictures. This is the picture of the oral cavity in which you can see the lichenoid changes, and these are because of the side effect of the immunotherapy. And second is the this skin rash is because of the nivolumab. And for the side effect of the immunotherapy, the recommended treatment is mostly steroids. Thank you very much. Or just in conclusion, I will say that after nearly a decade, we have 5 positive phase 3 studies of new drugs in HCC that improve the OS. First is the atezolizumab plus bevacizumab, which is shown to be superior to the sorafenib. Second is the lenvatinib first line. It is shown to be non-inferior to the standard of care, that is the sorafenib. That is regorafenib, which is the second line. It is shown to be superior to the placebo. Cabozantinib, which can be used in the second line or even in the third line, it is shown to be superior to the placebo. And the fifth one is the ramucirumab, which is given the second line when patient has the high alpha fetoprotein and is superior to the placebo. So for the first time, atezolizumab plus bevacizumab combination is superior as the frontline setting, and the in the first line, the level 1 evidence for the single agent immune checkpoint inhibitor is still lacking. So, and for the ongoing studies, studies are ongoing with the novel combination of immune checkpoint inhibitor with the TKI or PD-1 inhibitor with the CTLA-4 inhibitor. Thank you for Ms. Avnaj. This was all about my presentation.
Thank you, Dr. Reena. It was an excellent presentation on all the latest update regarding the chemotherapies available for the treatment of hepatocellular carcinoma. I would like to take small comments from Professor Sharbat Balki and Dr. Sikandar. Dr. Sikandar, I would like to ask, what is your experience in regarding latest systemic chemotherapy for HCC patients?
Regarding treatment of HCC patient, we always start with sorafenib if it is in the criteria beyond transplant. कुछ cases में ऐसा रहा है कि we have downstage successfully been able to downstage the tumor और उसको हम transplant के criteria के अंदर ला सके हैं. जो beyond criteria होते हैं normally हम sorafenib से शुरू करते हैं, and जो डॉक्टर साहिबा ने कहा बहुत खूबसूरती से, उन्होंने ये फर्स्ट लाइन थेरेपी में ये 2 ड्रग्स की कॉम्बिनेशन की जो स्टडी आई एम ब्रावो बताई है, तो नॉर्मली हमें इस चीज का एक्सपीरियंस इसलिए नहीं है कि वी सेंड सच पेशेंट टू द ऑन्कोलॉजिस्ट. ऑन्कोलॉजी के पास जाते हैं तो दे विल बी इन अ बेटर पोजीशन टू हाईलाइट के उनका कैसा रिजल्ट. और सोराफेनिब के साथ 4 to 6% से ऊपर आई हैवंट सीन समबडी डूइंग वेल. Very few patients I have seen doing good on sorafenib. एक केस जो कि अब तक मेरे लाइफ में एक्सपीरियंस में आई हैव कम अक्रॉस. I was taking the history of this patient in 2017, and this patient was suffering from hepatocellular carcinoma since 2010, and he was on sorafenib. Now, you can imagine a person who is on sorafenib surviving 7 years, and he was out of criteria of transplant, मतलब advanced HCC. So that's the only thing I can quote. The rest जो है तो हम oncologists के पास भेजते हैं, तो they are in a better position to say okay, what are the results of these second line drugs and other agents.
I guess we have a question from, thank you, sir. We have a question from Senior Vice President of PSLC, Dr. Shahzad Ahmed ji. Dr. Shahzad.
Thank you so much. A wonderful presentation. I just want to add a few things there. The cost of this drug is 5 lakh rupees with bevacizumab, 2 ampules and 1 ampule of Tricentric. This is atezolizumab. The company has given another thing that one dose, to purchase one dose, next dose will be free. So practically the cost is 2,50,000 for 3 weeks. After every 3 weeks, the dose should be repeated. I have 5 patients on this combination therapy. Actually, one thing should be remembered that this is first choice, first line, first choice. Sorafenib is first line, second choice. हमें ये करना चाहिए कि हमें प्रिस्क्राइब करने चाहिए इररिस्पेक्टिव ऑफ कि पेशेंट खरीद सकता है कि नहीं खरीद सकता. उसकी वजह ये है कि जब ये कॉमन होगी, जब ये पॉपुलर होगी, तो डेफिनेटली जो कंपनीज हैं वो प्राइस को कम करेंगे. दूसरी बात, जो हमारी इम्यूनोथेरेपी कॉम्बिनेशन में जो पाइपलाइन में भी जो आ रही है वो भी सारी बहुत महंगी हैं. उनकी प्राइसेस भी कम नहीं होने वाली. सोराफेनिब ने फॉर 12 इयर्स तक और आगे भी मार्केट पे ये काबू रहेगी. सोराफेनिब ने मार्केट को बहुत एक चला के रखा हुआ है. आप देखें, सोराफेनिब अगर नेक्सावार थी तो वो भी 3.5 लाख की इनिशियल थी, फिर उन्होंने 1+1 मंथ फ्री की, फिर आहिस्ता आहिस्ता इंडियन आ गई, और अब आप देखते हैं कि 10 में से 9 मरीज तो इंडियन सोराफेनिब ले रहे हैं. और जो डॉक्टर सिकंदर जिस पेशेंट का बता रहे हैं वो बेसिकली हमारा ही पेशेंट था, 7 साल जिंदा रहा 2010 से ऑनवर्ड्स. अच्छा, उसी तरह बहुत सारे पेशेंट जो पाइपलाइन में हमारे पास 4 साल 5 साल, क्योंकि वी डोंट नो कि एक्चुअली हम तो बायोप्सी करते नहीं है, हमें तो ये नहीं पता होता कि ये जो हेपेटोसेलुलर कार्सिनोमा है इसकी मॉलिक्यूलर वो क्या है, क्योंकि अब तो इस पे बहुत ज्यादा डेटा आ चुका है कि जो पुअर डिफरेंशिएटेड, वेल डिफरेंशिएटेड, इनकी रिस्पॉन्स रेट और इनका कोर्स ऑफ नेचुरल कोर्स है वो डिफरेंशिएट करता है. द मैसेज इज ये जो फर्स्ट लाइन फर्स्ट चॉइस है, इट्स गोइंग टू टेक पार्ट, ये टेक ओवर करेगा. और हमें चाहिए कि हम इसको ज्यादा से ज्यादा लिखना शुरू करें. सेफ्टी प्रोफाइल, जिस तरह डॉक्टर साहब ने बताया, बहुत अच्छा सेफ्टी प्रोफाइल है. हमारे एक पेशेंट में जिसको ट्रीटमेंट से पहले, उसकी 53 इयर्स ओल्ड एज थी, उसको ट्रीटमेंट से पहले कोई भी इस्कीमिक हार्ट डिजीज का वो नहीं था, उसको एक एक्यूट MI हुआ है. ब्लीडिंग डेफिनेटली हम स्क्रीन करके वेरिसेस को इराडिकेट करके वो करते हैं, तो अभी तक 5 पेशेंट्स में हमें ब्लीडिंग अभी तक नहीं आई. मेरे एक पेशेंट ने बैतुलमाल से अपनी रिलीज करा दी ये जो कॉम्बिनेशन थेरेपी है. तो द मैसेज इज के लिखना शुरू कर दें, चाहे उसको मिले या ना मिले. साथ साथ ये बता दें कि ये ना मिले तो तक आप सोराफेनिब लें, कोई इशू नहीं है. थैंक यू जी.
थैंक यू. डॉक्टर प्रोफेसर शरबत खान साहब से मैं कमेंट लूंगा. सर, आप एक ऐसे इलाके में बैठे हैं विच इज more socio-economically depressed for patients, na? So when it comes to systemic therapy with such an expensive load, what is the preferred drug of choice for treating HCC patients when it comes to chemotherapy? And what is the future of these latest advancements of chemotherapy in your region? Sir, kindly unmute your mic, please. सईद साहब, शरबत खान साहब का माइक अनम्यूट कर दें जी. यस, नहीं, इट्स अगेन म्यूटेड. It's again muted.
Can you hear me?
Yes, sir.
Yes. First of all, I'm very thankful to the Pakistan Society of Liver Cancer that they invited me as a chairman. And I am, it's very impressive that this is a very young society, but their academic takeoff is very good. This is a very fruitful activity for the PGs as well as the consultants. As you asked that, what is my experience regarding the sorafenib? Sorafenib or the other immunotherapies, because you know that the people in Pakistan are very poor patients and they cannot afford these costly therapies. We give the sorafenib, but due to the side effects and due to the cost of the patient left these therapies on its own after 1 or 2 months. And there are very minimum number of patients that they go through this trial up to 4 months or 6 months. But due to the side effects, they leave these drugs on its own, and when they come with the side effects, their side effects are very advanced, and we treat these side effects or they die before reaching us. So the results are not very good, and the impression regarding these drugs is not good in our area, because due to the side effects and the cost. And the patient asks that how much this drug will extend their life. When we say that this will extend your life up to 11 months. So this does not left a good impression on the patient, that when you extend my life up to 11 months and the quality of life is also not good. So they, first of all, they refuse this therapy, and they ask us that send me for the liver transplant, because the liver transplant is supported and by the endowment fund in Balochistan. So they try, first of all, for this, they don't know what's the criteria of liver transplant. So in conclusion, the results and the impression of these immunotherapy is not good in our area due to the cost and the side effects and the overall survival of the patient. Thank you.
थैंक यू सर. डॉक्टर रीना, बिल्कुल छोटे से आंसर्स रिक्वायर्ड होंगे क्योंकि वी हैव अ प्रेजेंटेशन हेडिंग एंड वी आर शॉर्ट ऑफ टाइम. कुछ क्वेश्चंस हैं हमारे पास पैनल से. डॉक्टर मसूद करीम साहब का क्वेश्चन है, नाइस टॉक्स. उन्होंने कहा फॉलो अप पेशेंट बता दें जिसको हमने एटीजोलिजुमैब और बेवेसिजुमैब शुरू कराया, ड्यूरेशन, लैब्स, एंडोस्कोपी के बारे में एंड रिस्पांस टू ट्रीटमेंट. और इमरान अली सैयद साहब PKLI लाहौर से, उनका क्वेश्चन है कि निवोलुमैब का आपका कोई एक्सपीरियंस हो.
Dr. Afan, we usually do endoscopy prior to starting the treatment, or if there are no varices, we can straight away start the atezolizumab. And we also check the autoimmune profile of the patient, and we usually take the history of the autoimmune diseases before starting any immunotherapy. And we take the history of any MI, stroke, bleeding in the past, or history of the patient if they are on anticoagulant. Then after that, after the evaluation, we start the atezolizumab and bevacizumab. And after giving 2 therapies, they are giving after 3 weeks apart, after giving 2 cycles, then we repeat the scan. And we usually check it on the modified RECIST criteria, HCC modified RECIST criteria. And with immunotherapy, we are well known that the patient can have the pseudo progression of the disease, and we should keep in mind that it in first 2 or 3 cycles we can have the pseudo progression of the disease. And if the patient who has no other symptom of disease progression and who's basically tolerating the therapy very well, we do not switch off therapy, or we do not switch off to any other line of the treatment. And if the patient who has the alpha fetoprotein raised at the baseline, and we usually check their alpha fetoprotein initially on the monthly basis as well. So initially we check it at the 6 to 8 weeks, and after that we usually scan the patient after every 3 weeks. Okay.
Okay. And nivolumab से experience आप?
Nivolumab.
जी.
Nivolumab, we have given nivolumab in other setting. I have not given nivolumab yet in the hepatocellular carcinoma, but we have given nivolumab in other malignancies, and yes, its side effect profile is very much tolerable. We give it to the old age patient with good performance status, and the side effect we usually see for the side effect of the endocrine abnormalities and which I have already explained. We usually see for that.
Thank you, Dr. Reena. We have another presentation, a quick short presentation on liver frailty index by Dr. Farhana. Dr. Farhana, kindly over to you. Unmute your mic, please.
Okay. I'm Dr. Farhana Kiani, and I'm actually from working as a gastroenterologist at Quetta. And I'm pleased to present on behalf of Balochistan wing of PSLC. And I feel being honored of such an active, emerging, and energetic organization. So the topic that is given today to me was regarding frailty assessment in patients with liver cirrhosis. So to begin with, initially, I need to reveal that there is no conflict of interest. So coming on to introduction, cirrhosis is said to be one of the major predisposing conditions that is actually of that leads to malnutrition, frailty, and sarcopenia. In patients with decompensated cirrhosis, the sarcopenia and frailty are mainly prevalent. The prevalence rate of frailty in patients who are waiting for liver transplant, it mainly ranges from 70 to 49. That seems to be a big number. So before proceeding to my presentation, we need to get known to the terminologies like frailty, malnutrition, and sarcopenia. So frailty is mainly defined by Freud as a biological syndrome of decreased reserve and resistance to the stressors. So this leads to decline in leads to the cumulative decline, and that causes vulnerable to the adverse outcomes. So regarding, and in contrast to that, the malnutrition is really defined as an imbalance of nutrients that causes measurable adverse effects on body tissues, and that leads to the function or the clinical outcomes. However, sarcopenia, that was defined by the European Working Group as a progression of generalized skeletal muscle disorder that is associated with adverse outcomes like falls, fractures, disability, and mortality. So coming to frailty, the frailty is said to be the phenotypic presentation of the impaired muscle contractile function. It is said to be a biological syndrome with the prognostic value. It mainly helps in predicting the mortality of the patients after liver transplantation. However, sarcopenia is said to be the phenotypic presentation of the loss of the muscle mass. In 20% of the compensated cirrhosis, the prevalence of sarcopenia is 20%. However, in 50% of the decompensated cirrhosis, it is prevalent. So it is also said to be a good predictor of lower survival. Along with that, it also helps in predicting the length of stay, the comorbidity, the morbidity, and the mortality. So the potential theories of pathophysiology of frailty mainly involves multi-system involvement, that is the skeletal system, neuromuscular, gut microbiome, endocrine, and immune system. So coming on to the pathophysiological changes, as I already discussed, that is the neuromuscular involvement. In neuromuscular involvement, there is loss of neurons in the brain that leads to impaired neuronal functions. Other than that, in immune system, there is a chronic low-grade inflammation going on in chronic liver disease with increased interleukins and cytokines, TNF factors, and elevated neutrophils and macrophages. So it helps in, it leads to the dysfunction, and it leads to the failure of a response to any stimuli. In the skeletal system, there are increased pro-inflammatory cytokines, so that causes increased muscle breakdown. And regarding gut microbiomes, actually the studies have not proven what is the main role, but it is said to be like they are involved in causing sarcopenia and frailty. Regarding endocrine system, the low levels of growth hormone, estradiol, testosterone, vitamin D, insulin-like growth factors, actually their low level and depletion mainly leads to loss of muscle mass. So these are the factors that are contributing to frailty and sarcopenia. And this slide is taken from the recent guidance that is presented by AASLD recently in July 2021. So regarding the etiological factors that are mainly related to cirrhosis, other systems like systemic inflammation, metabolic inflammation, physical activity, environmental factors. So these all contributes to leading to decrease of muscle mass, and along with that loss of muscle contraction that causes ultimately frailty and sarcopenia. So this further leads to decompensation, increased healthcare utilization, decreased health-related quality of life, ultimately death, and in cases of liver transplantation, it leads to adverse post-transplant outcomes. So the diagnostic criteria for sarcopenia and frailty. In frailty, the components that are included is weight loss, muscle strength, energy levels, and activity. Along with that, however, in sarcopenia, only muscle strength, muscle mass is involved. And these can be assisted by physical performance. However, these can be assisted by the weight loss can be assisted by the patient himself. However, the muscle strength can be hand grip strength, and the muscle mass, it can be assisted. We can assess that with the help of CT, MRI, DEXA, and BIA. However, energy levels and activity levels, they can be assessed by the patient himself, while the physical performance can be assessed by the gait speed of the patient. So regarding what is the clinical relevance of frailty in patients of like cirrhosis. So according to, the MELT score, which is actually commonly used to assess the liver disease severity and is used to prioritize organ allocation to candidates based on liver life expectancy. But this MELT score is mainly used to prioritize, but it does not take into consideration a patient's overall health. So it proves to be a poor predictor of post-transplant mortality. So the factors such as frailty is not considered in MELT. So in that case, we need to take into consideration the frailty and the sarcopenia, so we can assess the length of stay, increased number of hospitalizations, and the waitlist mortality also. So according to the recent the trials and the studies that were taken in the past, just to see the prevalence of frailty and liver index, it was shown like the minimum of 17% was prevalence up to maximum of 49%. So this shows that it is quite prevalent, and we need to take into consideration before prioritizing the patients for liver transplantation list. So the objective and the assessment tools of frailty mainly include Fried Frailty Index, short physical performance battery. And however, this is a list of a complete list of the tools that are used to assess frailty. It mainly includes Karnofsky performance scale, activity of daily life. Along with that, the most common one is Fried Frailty instrument, but the one which we are actually interested in is Liver Frailty Index. And as it is very easy and it can be done in ambulatory patients, and it is very easy and not time consuming as well. So regarding, there is another entity. What is sarcopenic obesity? It is actually a state of decreased muscle mass that is in the setting of increased fat mass. So it mainly represents a unique clinical challenge that it can be difficult to detect without dedicated testing, because fat mass can mask underlying muscle wasting. The prevalence can range from 20 to 35%. And so regarding this, it can be defined as low sex adjusted muscle index and BMI of more than 25 kg per meter square as an independent risk factor for mortality in patients with cirrhosis. So we need to know that sarcopenia does not only occur in lean patients, so it is also important mainly in our NAFLD related patients and ethanol related patients. So association, what is the association of sarcopenia? It is mainly associated with increased mortality, both before and after liver transplantation. It is associated with increased hepatic decompensation, reduced quality of life, increased risk of infection, and prolonged hospitalization. So, and similarly, the frailty is mainly strongly associated with increased mortality, that is both in ambulatory and acute care settings, and even in post-transplant settings too. So this actually emphasizes the importance of frailty in patients of CLD, both compensated and decompensated, and who are waiting for the transplant, and even after post-transplant conditions. So the diagnostic criteria mainly includes, like, what is that includes for fright frailty index, that is number one, weight loss. There is an unintentional weight loss of at least 5%, exhaustion, that that he feels like that at what time of day he feels like being exhausted, and the number is allocated respectively. And even in men and women, the walk speed is actually measured to give associated numbers, and to finally add them to know what is the scoring system. And regarding hand grips strength, it is adjusted in both in genders like men and women, and is adjusted according to the BMI. So if like the hand grip strength is above the cutoff points, so the number 0 is given, and there is no number given. And however, if it is below the cut points, so you give one number. And along with that, there is activity level that is self-reported by the patients. Similarly, it is divided into gender-based. So in men, it is like less than 383 kilocalories, and in women, it is less than 270 kilocalories. So according to this, if there is 0 score, the patient is not frail. But if it's in between 1 to 2 is pre-frail. And if it's 3 to 5, yes, the patient is quite exhausted and frail. We need to think of before going for any intervention. So the precise and the less time consuming and the bedside assessment that can be done in patients of CLD, and so it includes the functional assessment in liver transplantation, and that is liver frailty index. So in this, actually, when a liver frailty index along with MELD sodium, it can help in improving our risk prediction of mortality of patients going for liver transplantation. Cirrhotic patients who have higher MELD as compared to patients that have higher MELD and who are frail. So in those patients, we need to sort out that either do we need to go for liver transplantation, and they're said to have more higher mortality. It will also help to overcome the issues that are highlighted by LFI. So the liver frailty index, however, it cannot measure muscle mass. So in that cases, we need to have sarcopenia measurement. So, and further hepatic, in the only that is a limitation is that hepatic NCAF cannot be included in frailty. So the liver frailty index, it includes 3 components. Number 1, hand grip strength. Number 2, chair strength and balance. So hand grip strength is measured in men, if with the BMI of less than 20, but the strength is like up to 29, zero mass number is given, and the range is similarly given in the BMI range that are given below. But in female, they have another setting with the BMI of 23, the hand grip strength should be more than 17 kg. Similarly, it increases with the BMI, and if the cutoff level is, but the cutoff strength is less than this related to BMI, then we give a number of, then we give one number. So this is the chair stand, the second component. So in this, the patient is merely asked to have 5 chair stands merely completed in 50 seconds. So we measure that and we also give numbers. And similarly, the third component is balance. And in this, we ask the patient to stand like in a side-to-side position in semi-tendon and tendon. If the patient is like able to stand in 3 position for 10 seconds, then we give numbers that the patient is not frail. So the interpretation, as we discussed, like after adjusting the numbers. So if it is less than 3.2, the patient is not frail. If it is in between 3.2 to 4.3, the patient is pre-frail. And if it is more than 4.5, the patient is frail. So there is also a calculator that is available online, and we can merely assess that is very easily. However, this is the performer that is used at the Gumbert Institute of Transplantation. This is a small view regarding that. It mainly involves the frailty liver index that includes hand grip strength, chair stands, balance. And along with that, they also measure walk speed, activities of daily living, 6 minutes walk test, and sarcopenia assessment. And that is mainly done on the CT or MRI L3 vertebra level by just actually measuring the psoas muscle thickness. So now we come like regarding the guidance, like what is the guidance regarding the treatment of such sarcopenic and frailty patients? And this was actually recently published in AASLD in 2021. And according to it, all patients with cirrhosis should be assessed for frailty, and it should be done at the baseline and longitudinally. However, if a patient is like in compensated cirrhosis, we do it annually. But in decompensated cirrhosis, it should be done like 3 to 6 monthly. All patients with cirrhosis, they should be actually counseled regarding the risk and adverse clinical outcomes of frailty, and they should be actually counseled regarding the diet and the physical activities. So regarding frailty, it can be used in ambulatory setting. But however, the sarcopenia, it can be done who are not feasible or impractical, like in acute severe illness or inability to participate, such as in pediatric population. So regarding management, what are the 3 levels of disease prevention? At first, primary prevention, we need to actually prevent the development of frailty and sarcopenia. We need to assess the patient, and along with that, we need to educate them. We need to tell them like they have to think of their they have to emphasize the importance of physical activity and good nutrition. Moreover, along with that, we need to deal like with the decompensations like ascites and hepatic cath. In secondary prevention, that like early diagnosis is the key, and we need to promptly deal with the condition. So just to slow down the progression. So in this, we need to, what are the etiological factors that are leading it? And in these cases, we will start the management, and the management includes management of the decompensations. And along with that, we need to involve a multidisciplinary team that includes physiologist, physical therapist, the dietitians, and everyone, and even our nurses. But in tertiary prevention, we need to rehabilitate such patients. So in such cases, I will show ahead that what can be done. So this is an algorithm. All patients with cirrhosis, just to screen them for malnutrition, sarcopenia, educate them regarding the importance of frailty and sarcopenia, and what can be the adverse outcomes ahead. Along with that, just identify the contributing factors, go for the management strategies, and again, reassess the patient. So this is the algorithm that we need to deal with. This is the management box that mainly includes what are the etiological factors and what is the management. We need to manage the patient with ascites, hepatic INCAF. Regarding physical activity, we need to address we need to address the importance of endurance and resistance exercises. And initially, we have to start slow, and then we have to slowly build up. And similarly, the frequency should be around. The aerobic exercises should be like 4 to 7 days per week, and resistance exercise at least 2 to 3 days per week. And regarding nutrition, the caloric intake should be around 35 kilocalories. And similarly, the protein should be 1.2 to 1.5. So micronutrients, they need to be assessed and repeated. And we need to have dietitian in this setting also. So other systems, pharmacological therapies, as we discussed regarding the pathophysiological, hormonal involvement is there. So testosterone replacement and other like diabetes control is important, and even further new strategies are coming ahead to deal with frailty and sarcopenia in such patients. So as we discussed, that these patients should need educational resources and counseling, and for every patient, a personalized intake prescription is required. So to address his problems. Regarding treatment, that we know that what are the cirrhosis related conditions that we need to deal with, that what are the etiological factors just to manage malnutrition, frailty, and sarcopenia. Further, cirrhosis-related complications, as we discussed, hepatic INCAF and ascites. Even now, according to the guidance, that TIPS placement can also have an indirect effect of improving muscle mass. So regarding physical activity, yes. Yes, as we discussed, like endurance and aerobic exercise is required, and this should be actually tailored according to every patient. That after assessing their frailty, if the patient is like unable to walk, we cannot ask him to go for exercise. So as discussed before, that we need to start slow, and then we have to build up slowly. So regarding caloric needs, that should be personalized to the patients, and that should be done with indirect calorimetry. And if we cannot go for like indirect calorimetry measurement, so we use the traditional equation, that is Harris-Benedict equation. And if using the ideal body weight, you need to have a target of 35 kilocalories per kg body weight per day. However, in obese, it should be stratified. So in such patients, one more important thing that was actually given in the guidance of AASLD, and along with that in EASL, that we need to liberalize the use of sodium use in such patients who are actually not taking their diet. So we have to be a little liberal regarding the use of sodium. So regarding protein adjustment, as we said, it should be 1.2 to 1.5, and it includes the use of branched-chain amino acids. And the protein intake, it should not be restricted in hepatic INCAF. And a diverse range of protein sources must be used. It's not that like we need to just go for branched-chain amino acid supplementation. It should be a diverse range of protein sources. So it includes like chicken, beef, mutton, beans, fish, yogurt, milk. So this is a long list going on. So in carbs, it should be like, it include vegetables, fruits. Similarly, fat, it should be around 28% of the daily diet. So we have another, like, just to make everything easy, we have energy calculators also. So in such patients, fasting should be actually minimized, and just to avoid nocturnal fasting time, early breakfast and evening snack is recommended. So in cirrhosis, as we said, that sarcopenia, obesity, so in such patients, lifestyle advice is required. Physical exercise must be actually advised in such patients. Moreover, the dry weight needs to be calculated in patients with ascites and needs to be managed accordingly. So in guidance, like regarding weight loss, the weight loss should be in association and by the advice of dietitian and along with the physical therapist. And similarly, intake of target protein or physical activity is required to reduce the loss of muscle contractile function, that is frailty, and muscle mass, that is sarcopenia. So our question, like our next question is like how to deal with the nutrition in hospitalized patients. So in these patients, it is advised that we need to have formal consultation by dietitian within 24 hours of admission. The main aim is like to start with oral nutrition supplementation. If a patient is unable to take oral nutrition, we need to start enteral nutrition supplementations. However, just keep in mind like the risk of aspiration and hyperglycemia. Esophageal varices are actually not contraindicated to enteral need, and parenteral nutrition is only reserved for patients who cannot take enteral or like they cannot tolerate oral intake. So in patients who are critically ill, a higher protein target is set, that is 1.2 to 2. Similarly, micronutrient deficiency should be assessed. And now coming on to pharmacological therapies, it mainly includes testosterone replacement. It is mainly considered in selected men with low testosterone levels, and however, it is not given in patients who have history of HCC, malignancy, or thrombosis. Other pharmacological therapies that include L-carnitine, myostatin antagonist, direct mammalian target of rapamycin complex 1, and immunonutrition omega fatty acid, arginine, and glutamine, and nucleotides. However, the role is limited, and so there needs to be like further studies and trial to actually prove that. So this is the main picture, and that causes frailty and sarcopenia, and how do we need to target those. In neuronal condition, we need to deal with hepatic encapsulation, stop alcohol. And in cases of immune system, just prevent and treat in the infection. If low testosterone, starts testosterone therapies. And if the gut microbiome is involved in all this, this is start with microbiota rehabilitation by the use of rifaximin. And in case of frailty, if there's decreased diet, improve the nutritional intake. And if there is increased bacterial toxin, just treat the infections. And similarly, if there is an etiological factor like alcohol causing that, stop alcohol. Increase physical activity. And if there is mitochondrial target antioxidants that causes loss of muscle strength, so we need to adjust that. Branch chain supplements can be, amino acid supplements can be used to increase the muscle mass. However, in myostatin antagonist that causes the loss of muscle mass, so antagonist can be used. So this is the whole, like the key to the cause and the treatment of frailty and sarcopenia and liver-related patients. So as I discussed before, so this is a small brief overview regarding that. Thank you, everybody.
Excellent presentation, Dr. Farhana. हमारे पास लिवर ट्रांसप्लांट के पेशेंट्स आते हैं अक्सर, तो डॉक्टर असमत उनको देखते हैं फ्रेलिटी के लिए, हम साथ ऑब्वियसली देखते हैं। तो अक्सर हम एक जुमला बोलते हैं, पाकिस्तान में जिस किस्म की गैस्ट्रोएंट्रोलॉजी प्रैक्टिस की जाती रही है, शरबत खान साहब का मैं इस पे कमेंट लूंगा, या जो गैस्ट्रोएंट्रोलॉजी को हम टर्म करके यूज करते रहे हैं, शहजाद आमिर साहब जानते हैं। तो एवरी सीएलडी पेशेंट जिसका नमक भी बंद कराया होता है, बड़ा गोश्त छोटा गोश्त भी बंद कराया होता है, तो एवरी सीएलडी पेशेंट इन पाकिस्तान इज फ्रेल अनलेस अंटिल प्रूवन अदरवाइज, क्योंकि उनकी जो है हम लोग डाइट बिल्कुल बंद करा देते हैं, उनका नमक बंद करा देते हैं, उनका बड़ा गोश्त छोटा गोश्त अंडा बंद करा देते हैं। सो ये मिथ्स पता नहीं इस मुल्क में कब तक सरवाइव करेंगे। शरबत खान साहब, आप क्या कहेंगे?
Yes, I am agree with this, that in spite of the disease, we physicians are responsible for the main frailty of the patient, because we restrict the diet, especially these proteins and sodium, so they can't take. We even don't want to even check the daily blood sugar of the patient. Mostly the patients are hypoglycemic, they are sarcopenic, their protein malnourished. So we don't have any expert in the department throughout Pakistan to assess this frailty index. So this is a very good initiative by the Pakistan Society of Liver Cancer to assess this topic, because most of the physicians don't know, especially the gastroenterologist and the physician who practice gastroenterology in Pakistan, they don't know the frailty index. What are the components of the frailty index? What is frailty index, and what is the short physical performance battery? They don't know anything about this, but even I have noted in the ward that the patient is in hypoglycemia. He is in hypoglycemia, and they treat them for the hepatic encephalopathy. When we give glucose 25% 4 hours, the patient wakes up. So I have noted that even the blood sugar is not noted. They are so, especially in the public sector hospitals, this is very this part of the management is very neglected on the part of the physicians. So they don't even do the blood sugar level of the patient on daily basis. The patient is an hypoglycemia, chronic hypoglycemia, and they don't replace it daily. So the frailty index is a very far assessment that they may do daily or on week basis, monthly basis in the ward. So this is a very good topic initiated and discussed by you, and every physician should know all these things. What are the components of the frailty index? What is the importance of frailty index? What is the impact of the frailty index, high frailty index on the overall survival of the patient, especially in the transplant patients. So this should be discussed in every webinar and every symposium. This topic should be discussed, and every physician should know all the aspects of this and the importance of this topic, and they should apply it in their ward, in their departments, so the patient will be benefit by this, and the overall survival will be improved, especially those patients who are on the waiting list of liver transplant. If the frailty index, frailty index comes down, the patient will be fit for liver transplant, and the outcome of the liver transplant will be good. Thank you.
Thank you, Professor Shargat Khan Saab. Dr. Asmat Shahwani is our Balochistan lead for PSLC, and he is behind core of this webinar today, because it is by the Balochistan team of PSLC. Dr. Shahzad Amir has a question.
बिल्कुल, very nice presentation, Dr. Farhana. Many things we learned today. Actually, आपकी बात बिल्कुल सही है, डॉक्टर आफान के इस मुल्क में मेडिसिन के साथ इन्वर्टेड कामाज में स्पेशल इंटरेस्ट इन गैस्ट्रोएंट्रोलॉजी, और अब तो माशाल्लाह स्पेशल इंटरेस्ट इन हेपाटोलॉजी भी लोग लिख रहे हैं। और लिटरली ये अभी से नहीं, गुज़श्ता 12-13 सालों से जब हम ट्रेनिंग शुरू की, हम देख रहे हैं कि नमक भी बंद, गोश्त भी बंद, दालें भी बंद, सब कुछ बंद। और जो नेचुरल कोर्स एक पेशेंट का कंपेंसेटेड सिरोसिस के साथ उसका 1 ईयर सर्वाइवल अगर 95% है, उसको भी बेचारे को स्पीड अप कर देते हैं उसका आखिरी सफर। बहुत सारी चीजें हम एज अ गैस्ट्रोएंटरोलॉजिस्ट हमें भी नहीं पता। लास्ट जो हमारी वेबिनार थी, जो कि प्रोफेसर हमारे खान साहब उसको चेयरपर्सन जो कर रहे थे, उन्होंने एक बहुत इंपॉर्टेंट बात की थी। यही एक मैसेज मैं भी देना चाहता हूँ कि जो हमारी प्रैक्टिस में हम एक्चुअली बड़ी आसानी से हम कहते हैं कि 35 किलो कैलोरीज पर केजी पर डे आप पेशेंट को लें, लेकिन मल्टीपल फैक्टर्स होते हैं, उसमें एपिटाइट का भी होता है और बहुत सारी चीजें होती हैं जिसमें पेशेंट वो पूरी नहीं कर सकता। तो एज ए फिजिशियन अगर आप देखते हैं कि मेरा पेशेंट ये चीजें नहीं पूरी कर सकता, या आप एक्सपेक्ट कर रहे हैं कि मैं उसको लिवर ट्रांसप्लांट के लिए रेफर कर रहा हूँ, जो बहुत इंपॉर्टेंट है, हर पेशेंट को, खासकर वो रिलेटिवली यंगर एज में हो, 50s में हो, आप डेफिनेटली लिवर ट्रांसप्लांट के लिए उसको रेफर करें। उसका ट्रांसप्लांट होता है नहीं होता, जो रीजन भी हो, आपने रेफर करना है। उससे पहले आपने उसको बिल्ट अप करना है। उसके लिए जो लास्ट टाइम बात की थी कि डेफिनेटली हम लोग डाइटिशियन के पॉइंट ऑफ व्यू से भी स्ट्रगल कर रहे होते हैं, लेकिन ये भी सॉर्ट आउट हो सकता है। जो एनजी फीडिंग है, इंट्रल फीडिंग, एंट्रल फीडिंग में पेशेंट को कौंसल करके फाइन बोर 12 फ्रेंच की 14 फ्रेंच की 10 फ्रेंच की भी आती हैं, लेकिन वो आजकल कम है। उसको हम पास करके उससे हम ग्रेजुअली इसकी न्यूट्रिशन इनटेक बढ़ा सकते हैं। तो ये इवन ओपीडी बेस पे घर घर पे वो कर सकते हैं। हाई प्रोटीन डाइट बनाने का तरीका बता दें कि ब्लेंड राइस करके वो करें। तो ये एक प्रैक्टिस है जो कि सिंपल सी है, लेकिन हमने देखा, हमने बहुत ज्यादा प्रैक्टिस की अपने लिवर ट्रांसप्लांट के पेशेंट्स में भी। 3 to 4 वीक्स में देते थे हम, बड़ा एक वाजे फर्क। तो इररिस्पेक्टिव ऑफ मसल कंट्रेक्टाइल डिसफंक्शन हो या इररिस्पेक्टिव ऑफ मसल लॉस हो, दोनों में एंड जो कंक्लूजन वो तो है यही कि आपने उसकी न्यूट्रिशन बिल्टअप करना है। आपने उसको मैक्सिमम कैलोरीज और विद प्रोटीन, हाई प्रोटीन, मतलब 1.2 से 1.5 ग्राम पर केजी पर डे से। तो एनजी फीडिंग को प्रोमोट करें और ज्यादा से ज्यादा शुरू करें। खुद एनजी पास करें, 12 फेंच की एनजीज मंगवाएं। पेशेंट वेल टॉलरेट करता है, इवन उसको कहें कि वो मुंह से भी साथ साथ लेते जाए, बाज दफा होता है। तो डॉक्टर अफान, हमारा काम तो माशाल्लाह बड़ा बढ़ाया हुआ है, क्योंकि जब हम पेशेंट को कहते हैं कि आप सब कुछ कहें, तो वो 1-2 मिनट तक हमारा मुंह देख रहे होते हैं कि डॉक्टर साहब क्या बात कर रहे हैं आप मुझे मतलब मारने वाले हैं। परहेज भी तो इलाज है। बहरहाल यही मेरा कमेंट था। थैंक यू।
मरीज को कहें कि नमक खा सकते हैं तो वो हमें ऐसे देखते हैं जैसे हमने कोई गुनाह कर दिया उनको ये बात कह के, फिर उन्हें हमें बताना पड़ता है कि जो आप सुनते आ रहे हैं वो गलत है। जी डॉक्टर असमत। Dr. Asmat, you have a voice problem. I guess you have a voice problem.
Chacha, thank you so much for Mr. Shabat Khan for his nice comments and nice wording regarding the PSLC forum. And thank you, Dr. Farhana, as well for such a nice presentation. Quite different about चीजें भी हमें सुनने को मिली। और बेसिकली मैं एक पॉइंट ऐड करना चाहता हूँ इन शॉर्ट कि we are working in a high-volume sector where patients they travel far from the country. So enlist the patient for transplantation is not a big problem, but to optimize a patient for transplant is a big challenge because सारे country से कहते हैं कि बस आप transplant कराने चले जाएं. But it's not so much easy. Patient they are frail, they are sarcopenic. To optimize them, it is a major challenge. So ये LFI का bedside assessment measures लेके ही आप एक characteristic parameter develop करें ताकि every physician and gastroenterologist के लिए तो आप must have these all the जो practice कर रहे हैं they should must be about this LFI और assessment को थोड़ा सा कर सकें because ये जो सेशन है ये कंटिन्यूटी है। डॉक्टर एहतसाम ने लास्ट वेबिनार में एक प्रेजेंटेशन दी थी न्यूट्रिशन के हवाले से, डॉक्टर फरहाना ने LFI के हवाले से दी। So LFI can highlight the issues the enlisted transplant patients. क्या issues highlight हुए हैं, उसी issues को दोबारा से आप overcome करना है। बेसिकली दो issues आए, अगर patient की low down patient वो patient जिसकी स्टेट्स अच्छे नहीं है, जिनका बैलेंस अच्छा नहीं है, ये वो पैरामीटर्स हैं जिनको आप ओवरकम कर सकते हैं और दे कैन हैव इम्पैक्ट ऑन योर सर्वाइवल एज वेल। आई होप पेशेंट्स, माय ओन पेशेंट्स जो हमारे ट्रांसप्लांट के हो चुके हैं, हमारे फॉलो अप है, सो वी विल इंशाल्लाह शेयर डेटा ऑन दिस फॉरम एज वेल कि जिस पेशेंट को हमने ऑप्टिमाइज किया है, पेशेंट को दे वर फ्रेल LFI तो क्वांटिटेटिव है पेशेंट्स उनको हमने ऑप्टिमाइज किया है। अल्हम्दुलिल्लाह 3 पेशेंट्स दे हैव गॉन वेल। एक पेशेंट हमारा अभी तक एडमिटेड है, इज 8 पोस्ट ऑप। सो थिंग्स दे कैन गेट बेटर विद दिस ऑप्टिमाइजेशन। नेक्स्ट टॉक मेरी एक सजेशन होगी, जो नेक्स्ट हम रखेंगे कोई भी वेबिनार, उसमें डॉक्टर फरहाना ने वो डॉक्टर एहतसाम ने जो लास्ट टाइम वेबिनार में जो पॉइंट्स हाईलाइट किए थे, तो हमारा ये होगा कि रोल ऑफ ऑप्टिमाइजेशन, स्पेशली जो रोल ऑफ ऑप्टिमाइजेशन है। So a gastroenterologist should be a good physiotherapist. A gastroenterologist must be a good dietitian as well, because you should be you are the one who is close contact the patients. So हमें ये सब पैरामीटर्स देखने चाहिए। जैसे शबा साहब ने अभी सर ने बात की कि हाइपोग्लाइसीमिया की वजह से पेशेंट जो ना वो हाइपोग्लाइसीमिया में हमें ये नहीं पता, तो it is a thing that should be। और इसी तरह से हमारी आपस की डिस्कशन से चीज की इन्वॉल्वमेंट के साथ ये सारी चीजें बेहतर हो सकती हैं. I think it will be better. So next talk will be inshallah ta'ala, if I get opportunity, I will be open to have talk the role of optimization.
Thank you. Thank you.
Thank
We from participants we have one raise hand. If I would request Dr. Said to bring him up.
Dr. I have tried, but he declined my request. Dr.
Okay.
Wajid.
Dr. Sikandar, I would like to take your comments on frailty and transplant. The Dr. Sikandar, can you hear us? Dr. Irfan.
Ji, Dr. Khan, thank you. Thank you, everyone, especially our chairpersons and our speakers. A very nice presentation regarding chemotherapy and very neglected and important topic, diet in cirrhosis patient. डॉक्टर अफान, मैं भी जैसे डॉक्टर शरबत ने बताया, मैं रोजमर्रा पेशेंट देखता हूँ सिरोसिस के बहुत ज्यादा. तो बिल्कुल ऐसा ही कंसेप्ट है, हमारे लोगों की सारी डाइट बंद की होती है और हमने देखा है कि प्रोटीन की ज्यादा जरूरत है, प्रोटीन भी बंद है, साइटीज है माइल्ड सी या इवन मैसिव साइटीज है, तो पानी बंद है पेशेंट का. तो सिरोसिस के पेशेंट्स में कोई चीज मुकम्मल तौर पे पेशेंट की बंद नहीं होती है. ये बड़ी इंपॉर्टेंट चीज है, कोई चीज बंद नहीं होती, लेकिन हमारे पेशेंट्स को बहुत कुछ बंद कर दिया जाता है. मैंने अपने सिरोसिस के बहुत सारे ऐसे पेशेंट्स देखे हैं, जिस तरह सर ने बताया कि उनको हाइपोग्लाइसीमिया होता है ड्यू टू रिड्यूस्ड ओरल इनटेक, कि जिन पेशेंट्स को मैंने मेडिसिन कम करके उनको अननेसेसरी बहुत सारी मल्टीविटामिन्स और दिस एंड दैट दिया होता है और डाइट उनकी बिल्कुल रिड्यूस्ड होती है. हम फुल ऑप्टिमाइज करके गाइडलाइंस ये कहते हैं कि दिन में सिरोसिस के पेशेंट को 6 खाने दें, 6 खाने, 3 सुबह दोपहर शाम फुल फ्लैज जो मेजर मील होता है और 3 जो है वो स्मॉल मील्स इन बिटवीन मेजर मील, और इसी तरह रात को सोने से पहले छोटा खाना एक जरूर खाए पेशेंट. हमारे क्या होता है, 6 खाने की बजाय मरीज नॉर्मल 3 खाने भी नहीं ले रहा होता. और मेरा पर्सनल एक्सपीरियंस ये है कि जिन पेशेंट्स को हम, जो पेशेंट मेरे इन 6 खानों वाली बात को फॉलो करते हैं, वो 1-1.5 माह में बहुत ज्यादा इंप्रूव करते हैं एज कम्पेयर टू दोस्त के जो इनको बिल्कुल फॉलो नहीं कर रहे होते, क्योंकि मोस्टली उन्हें यही कहा जाता है कि आप बिल्कुल ना खाएं. इसी तरह नमक बंद नहीं होता. जो पानी है, पानी भी सिर्फ उस सूरत में बंद होता है अगर डाइल्यूशनल हाइपोनेट्रीमिया हो, अदरवाइज पानी बंद नहीं है, चाहे मैसिव साइटीज है. हमारे पेशेंट पानी भी छोड़ देते हैं. तो ये बहुत इंपॉर्टेंट टॉपिक है. वेरी नाइस टॉक, थैंक यू सो मच मैडम. एंड इसी तरह जो मैडम रीना ने कीमोथेरेपी प्रेजेंटेशन दी है, वो भी बहुत नाइस प्रेजेंटेशन थी. उसमें जो उन्होंने डाटा प्रेजेंट किया है वो भी अप टू डेट था हमारे लिए, उसमें बहुत लर्निंग पॉइंट्स थे. एंड थैंक यू एवरीवन हु पार्टिसिपेटेड. थैंक यू सो मच.
Thank you. One last comment from Dr. Fakhr Ali Qazi Saab.
Thank you, Afnan. I think that was a great session. I don't have more words to praise it. The only thing is, this is not restricted to liver transplantation. This issue is with all cirrhotic patients. So we should not focus on using liver frailty index or any other frailty score in transplant population only. This should be done in all liver patients. This is actually an emerging topic, and we are always lagging behind US and UK in all these stuffs. Dr. Jennifer Lai is the guru of liver frailty index, who works in UCSF California, and she has multiple publications on liver frailty index, and both pre-transplant and post-transplant. The other thing I highlighted in the previous session as well, this liver frailty index required hand dynamometer, which may not be available in all centers. Although it's cheap, they can buy, but we should focus on other options as well. For example, we use clinical frailty score, which is a subjective score, and we have shown that this was significantly associated with a waitlist mortality. I'm going to publish it soon. This has been accepted as AASLD poster of distinction for this year, so I cannot go into details of this study given the embargo policies, but hopefully you will find it soon.
Thank you, Dr. Fakhr. Dr. Sikandar, thanks for chairing. Any last comment? We are ending up the session. Unmute your mic, please. kindly unmute your mic, please. It's still muted. Dr. Saeed, if you help, please.
Yes.
ठीक है?
Yes.
Afan, ठीक है?
Yes.
Dr. Reena, Dr. Farhana, thank you so much. It was a wonderful presentation. Or Afan, I congratulate you on starting this initiative. और concluding statement मेरा यही है, जिस तरह डॉक्टर शहजाद आमिर ने कहा कि we should start prescribing immunotherapy. आगे patient की affordability, that's not our issue. Let's leave it to the government. Let's leave it to the sponsoring authorities. दूसरा ये है कि as for the frailty test, डॉक्टर फरहाना ने बहुत खूबसूरत इसको highlight किया, and I think the gastroenterologist के level पे इस चीज को address करना चाहिए कि nutrition should be sorted for the pre-transplant patients because it has a dramatic effect on the outcome of the transplant. Thank you.
Thank you. Thank you to all respected chairs, panelists, and our worthy speakers. What an excellent session of presentation. Inshallah, PSLC इस तरह के webinars कराती रहेगी. We will for next we will go with one speaker and with lots of discussion on the concerned topic. Thank you very much for attending this session of Pakistan Society of Liver Cancer. Thank you very much.
Thank you.
Thank you.